For those of you who may have missed the first session, Dr. David Pension is the director of the NHS Sustainable Development Unit, which gives him a great deal of credibility in engaging in this session on what does disruption in healthcare mean for doctors and patients. I think we've had a brilliant introduction to that from Jen, and that's we're most grateful to you for that and for its honesty and clarity. True to your discipline, you're a great communicator, so thank you. Our second presentation comes from Robyn Toomath, who hails from Auckland, where she's the Director of General Medicine at Auckland Hospital. And outside of general medicine, she co-founded the activist group FOE, F-O-E, Fight the Obesity Epidemic. And in 2001, she published a book, Fat Science. And she will discuss her efforts to lead an open notes project in the general medicine department at Auckland Hospital. Robyn Toomath.
I'm going to be terribly rude, actually, and not talk about the thing I said I was going to talk about. Is that all right? Yes.
As long as what you're going to talk about is more interesting.
So the challenge that was put to us earlier today by David about becoming activists, I think, is something that we, often think, oh my God, yes, I've got to do something, but how do we get there? So if you don't mind, Mr. Chairman, I thought perhaps I'd just tell a little story about how you move from being an advocate to an activist. And give you some advice about that. The answer is by accident, I think, often. And my particular story, relates to FOE rather than open notes, which might have to wait for another day. But when I was the president of the New Zealand Society for the Study of Diabetes, I thought to myself, this is an opportunity to make some noise about something that's important to me. I'll use this little window of opportunity to see if I can give some leverage to the problem of obesity, which when I started as a diabetologist, believe it or not, was not perceived as a problem. We saw all of the patients with diabetes in our outpatient clinics, everybody, including those with type 2 diabetes. There were few of them. But during the first few years as a clinician, I started to become aware of this great sort of tidal wave coming my way, and I felt a fraud sitting here in my little consulting room, seeing one person come in and out every 20 minutes or so, aware that there was this great wave of diabetes coming our way, and the penny dropped that sitting in my consulting room was not the way to solve this. We had to get out there and deal with the driver of the diabetes phenomenon, which was the obesity epidemic. So having been appointed to this role, I spoke to Boyd Swinburne. Professor Swinburne, many of you will know, was the sort of leader of obesity activism in New Zealand before, sadly, he came to Australia. But I met up with him in Kuala Lumpur one day and said, okay, Boyd, what am I going to do? I want to really put my efforts behind obesity prevention. Which is the group that we should be backing in the diabetes world? Should we be backing? There were a group of people, the Heart Foundation and so forth. He said, no. He said, nobody in New Zealand understands advocacy. You'll have to form your own group. And I said, oh yeah, I had no idea what he was talking about. Anyway, the CEO of Diabetes New Zealand and I then spent the afternoon playing around with words, and we came up with the title FOE, Fight the Obesity Epidemic. And so we told each other that we'd formed this group, and so there it was, it came into being. So that's all you have to do. And then I returned to New Zealand and started doing all of the things that I knew about from my medical school experience and training and so forth. And I started knocking on the doors of people in high places and talking to them about how important it was to do something about obesity. So I met up with the Director General of Health. I spoke to the top people, in the ministry, and I started making appointments with politicians. And I went in there as an expert, expecting that all I had to do was to explain the logic of the situation, that we had to introduce taxes, we had to get rid of advertising, and people would say, gosh, that's a really good idea, and then they would just do it. So it took a while to realise that this wasn't the way things happened. The time when I stepped across the divide, I think, which is from working as an expert doctor to rabble-raising as an activist, came when the day when my friend and colleague Sarah, the CEO of Diabetes New Zealand, rang me up and she said, you have to come to this launch of the new broadcasting standards, the new broadcasting standards for television. She said, they're having a launch, it's got television, it's on this afternoon at 5. And I said, oh, I haven't got an invitation for that. She said, just a moment. She picked up the phone and she said, Dr. Toomath will be coming along as a guest to this thing. And I said, oh, righto. Anyway, we got down there and there were television cameras and politicians and so forth. And a politician was talking about how fabulous it was that they were producing these new standards for the content of television programs. And then there was a sort of at the end of the talk, they said, are there any questions from the floor? And my friend Sarah stepped back, leaving me sort of in the front, and I said, oh my God, I've got to say something. So I then loudly complained about the standards with regard to advertising and said what was going to be done about this. Well, there was a sort of a hush because this was supposed to be a celebratory thing for the politicians, and somebody turned around and looked at me aghast. The person from the Advertising Standards Authority looked as if they wanted to rip my head off, and lots of television people took quite a lot of interest, and suddenly I realised that I had crossed the divide and that this was something over subsequent years I learned to do time and time again, which was to speak loudly, to say the same things over and over again, to speak in sound bites, to speak at the level of a 12-year-old, and to walk away from the serious medical training that I'd had and occupy a completely different role. So there is a huge difference between acting as an activist out there in the media and the training for to be a medical advocate. And I'm just thinking whether I should stop at this point and say there are I could talk about that. I'll just say one more thing about being once you've crossed the divide, there really isn't any going back, and you realise that that anything is actually possible. And I have kicked up the dirt in lots of different areas over the time. In recent times, with regard to the obesity issue, I've spent more of my time within the hospital talking to doctors and being provocative with my medical colleagues. One of the things that I learned after I had been advocating for a while about changes in the public health arena, I decided it was time to examine what we were doing in medicine as well. And I realised that it was totally farcical to say that the drivers of obesity were outside the control of individuals, which I believe. I believe that the combination of genes and environment determine our body size, and at the same time to see people in clinic and suggest that they lose weight. So about 10 years ago, I stopped asking individuals to lose weight. I never ever ask people to lose weight. I don't believe it's a realistic question to ask of people. I believe it's something that does more harm than good. And some time ago, I tried to disband weight loss clinics in the hospital, creating a great deal of distress amongst my dietetic colleagues. I don't think I've quite succeeded on that one yet, but I'll continue to work away on it.
Thank you very much indeed, Robyn. This is great. It's really innovating. Can I start by just asking you the same question I asked generally, which was, when you teach, because many of us here have educational roles as well as our clinical roles. When you go and talk to a medical school, when you get invited along to give a lecture, you often don't need to ask which year of the medical school they're in. Because if you're in the first year, they're bright and and they're smart and they're engaging and they've got lots of questions. And in the 6th year, they just say to you, look, if it's not in the exam, I'm not going to stay. So what is it that we can do, in the same way as we were talking about patient empowerment and public empowerment and giving people agency to manage their own health and determinants, what is it? You very eloquently describe the difference between being a stimulant and an irritant. I'm going to pick you up on that because I think it's a point worth challenging. What is it that we can do to keep that candle burning in medical students to be very good clinical doctors and social activists at the same time?
Well, I think being an irritant is a lot of the answer, actually. I think you can turn things on their head. I mean, I love Jen's talk. I mean, I think continuing to reflect back the patient's perspective is incredibly valuable. It's certainly the case for obesity, you know, the whole issue about why is somebody obese, you know, and if you continue to tell the story from the patient's perspective, you know, horrifyingly, that is a provocative stance to take in medicine, you know, at any level. So, yeah, I think that's the most useful thing to do.
Okay, so let me challenge you on the other. You said very, very humorously, you know, you crossed over the divide from being, what were the words you used? From being a sort of stimulant to be in, there's no going back. Do you not think that actually we could do, I'm just thinking some of the most effective medical social activists have been arsey when you need to be arsey, but incredibly diplomatic when you need to be diplomatic. And I wonder if there's a skill about us being chameleons, honest chameleons, by, you know, partly being the advocate of the patient and partly being the advocate of the public, but also stopping being, if you like, an advocate of the profession, as though the profession is the thing that matters most. I mean, when you see some of us, when I hear myself talking sometimes, I think, actually, whose interests am I speaking in here? You know, and sometimes it's the preservation of the status quo, not in terms of, you know, my job. I'm here to help you help yourself, or I'm here to change the system to help you better.
Yeah, I mean, I think the thing is that you can be a whole lot more audacious than you might expect and get away with it. This is what the crossing the divide, you know, involves. And I mean, the other issue that I was supposed to be talking about today was the question of open notes. And I came back hugely inspired from a talk by Tony Del Banco. Now, some of you will know about the open notes movement, Nothing About Me Without Me. And he spoke at a meeting in Paris some years ago, and I came back with this burning desire that we would have open notes within our hospital. It's quite tricky. In fact, I've failed. I'm going to say that right up front, but I'm still pursuing this. But I decided, once you've had the flip in your head, oh my God, of course the patients should hone, these are their notes. What on earth are we doing, keeping them in the nursing station? They belong to the patients. And so I came back determined that I should do this, expecting all sorts of resistance, and in fact getting quite a lot from the people with whom I worked. But in actual fact, the CEO of the organisation, the head nurse of the organisation, thought it was a fantastic idea for reasons that I hadn't anticipated. And for example, the head nurse of the organisation had been driving for some time a program called Releasing Time to Care. They want nurses to spend more time at the bedside. So they were desperate for patients to, for nurses to sit down with the notes beside the patient and say, "Hi, Mrs. Bloggs, did you get any pain today?" Or "Did your bowels move?" Or, and to be sitting beside the patient, able to give them a glass of water if they also needed it, or take them to the toilet. So for reasons that I hadn't anticipated, they were huge supporters of this issue of bringing notes to the bedside, and very, very disappointed that we weren't able to achieve it.
So one of the lessons there is that you'll sometimes find allies in places you weren't
unlikely
looking.
places.
In unlikely places. We need strange journeys need strange bedfellows.
Yeah.
And we've got to be open to that. But let's go back more practically to why you think you failed so far. It's not weight of numbers. Is it this sheer incalcitrance of people who want to preserve historic systems? Yeah,
it was, all sorts of things. We did a great survey before we started this whole program, and we asked patients, families, and a whole range of health professionals what the effect of open notes, what they anticipated the effect of open notes would be. And so the doctors all thought that the patients would be worried about, what was there, they'd be confused, and none of the patients did. The doctors all thought it would be a terribly bad thing. No, that's not true. Some of the health professionals thought that having the notes available to the patients would be scary and overall a bad thing. 85% of the patients thought it would be terrific. But I think it was inertia largely that caused this particular experiment to fail. It's pretty impractical when you've got physical notes. We may have to wait until we get electronic notes. but the notes just migrated back and back and back into the workspace. And I was quite sure that the way to get it achieved eventually was just simply to remove all the note storage in the wards. And I just didn't have quite enough backing to be able to strip out the guts of the ward officers, but I think that's what's required. But I think also, the other thing is that I was thinking, if as the patients come through the door, they are handed an empty folder and said, these are your notes, Mrs. Bloggs, this will be where your notes go during your time in hospital. And if all of the, massive notes that you acquire during the hospital come, to the patient in their folder from the word go.
Yeah. So I've been very surprised by how, just like sometimes you need strange bedfellows, sometimes the strangest levers. So I'm just fantasizing about, do you have a Freedom of Information Act here? I mean, you can use, we have no right to keep information from people. So, I mean, and as I was saying earlier, legal levers are quite important. And I'm just wondering whether the process of you trying to change things is as useful as the end product. You might be dispirited, you might be discouraged, but actually having these conversations of trying to change it illuminates the minds of lots of people who might otherwise be quiet. And I think it's often said that, leaders good leaders create more followers, great leaders create other leaders. So in you, through your actions and your courage, inspiring other people in sometimes quite strange parts of the system, and probably picking up on Jen's point, patients saying, they want the notes there on their bed because when their family come in, they like to have something real to discuss and maybe offer help to the system, and portraying it more as a collaborative exercise, not a confrontational exercise. And I think we, as doctors, do you think we fear this? Do you think we fear leaving, because we're brought up in a hierarchical system, we just don't trust, we fear our power or our authority seeping away, when in fact the reality, the evidence, for instance, from patient-held notes in developing countries, after all, is that you get a better outcome.
Well, to be honest, I don't think it was the fear. It was, we have a great deal of problem with this, the Privacy Act. I mean, we've, the balance between, privacy and transparency. It is a balance, and as far as I'm concerned, we've gone way too far, in terms of privacy. And it's an absolute nonsense. I mean, we examine our patients and talk to our patients in 4-bedded cubicles with curtains around them, You can go in there and you can be hiding behind the curtains and say, have you had any problems with your breathing today, Mrs. Bloggs? And she said, no, dear, it was lovely. And the person from across the room says, that's rubbish, she was coughing all night, So, so it's a myth, it's an illusion. Yeah. And in actual fact, the people who were most resistant to the open notes were actually the social workers, who I think are trained in this whole world of secrecy and privacy. So, and they contributed to the notes. And they were actually the most resistant group. But from my perspective, a real opportunity for not just communication, but also safety, is having the notes so that the relatives can read the notes. Yeah. I mean, we have about a third of my patients don't speak English, and you can have an elderly Tongan woman sitting in bed and her lawyer daughter could be working all day and come in at 5 o'clock. I love the idea that she could come and pick up the notes. What I really wanted to get to was the point where not only would the patients read the notes, but they would write in the notes. Yeah. So having the daughter come in and say, did you know that mum had bleeding from the bowel last week, and add that to the notes. This is where I wanted to get to, and maybe we'll get there one day, but I haven't mentioned it yet.
Maybe you need some real examples of better outcomes having been delivered, because this is, and one of the, I think one of the lessons of controversial change. I mean, I remember in the UK there was a great controversy about televising Parliament. The House, I'm sure you do it here, but there was a great controversy here. So the easiest way, sorry, it's boring.
It's very boring.
No, it's very exciting in the UK. It's very exciting. Was to say, well, let's do it as a pilot. How can you argue about not doing it as a pilot? We can easily scrap it after 3 months. And as soon as people see the benefit, it's got an unstoppable social momentum where it would never go back. How could you ever take cameras out of Parliament, and how ridiculous would that be? And I think the people who organised the pilot knew very well that this was a one-way journey. So I just wonder about opportunities for you to use narratives or stories or real people or angles like safety or clinical outcomes.
I use them all. I use them all.
I'm
And
sure
we
you
had
do.
and we had a pilot, and I had the backing of the CEO and all of the senior executive team, and I had the performance improvement team on site.
Yeah,
You know,
God,
doing
gee.
surveys. But you know, every now and again, the rigidity of the system is really fascinating. You know, I think it does need something very disruptive, more than me just being in there kicking up the
Yeah.
dust. It needs actually some, as I say, it probably needs a bulldozer into the workstation to remove all of the shelving from the notes. It needs some physical system fix.
Yeah, yes, you do need to be disruptive. The other thing, I think you need to be ready for change. I've seen lots of examples of people trying to be quite revolutionary, banging on doors, wanting change, and as soon as the door opens and someone says, okay, do it, they go, oh my goodness me, they haven't got it ready. So it sounds like one of the virtues of what you've been doing is if you
We are
were given
ready.
carte blanche,
Yes.
you would be ready. So,
Yeah.
you know, one word of advice, it's great fun to whinge and whine, but one day you might find someone will open the door and go on, do it then. So, and we've had occasions like that. I know that, for instance, getting tobacco out of the London Underground or the Metro, a lot of whinging and whining, and we were lucky that when the opportunity arose, tragically through a terrible fire, that all those people who'd been activists could move from being activists, morph very quickly into implementers. And I think sometimes that's the advantage of a team, is in a team you sometimes have activists, but you need ruthless implementers as well, and you've got to have both of those arms going.
Well, I think as soon as we get an electronic record, it'll flip. It'll be so easy to have patients having access, you know, to their notes with an electronic record. And perhaps we're going to hear about electronic records from Ian.
Lovely. Well, thank you very much indeed, Robyn. That was
Thank
great.